Good evening, dear colleagues. Hope we're all doing well. Thank you very much for joining us. I think we'll start. Today, we'll go straight into looking at the case studies. Remember, the first Saturday, we took cardiovascular, cardiopulmonary, neuro, and I think GIT. And on Wednesday that followed that Saturday, we studied a number of case reports. And then last Saturday, we continued from where we stopped and took hepatic and biliary system, I think hematological, and a number of other systems. So today we are going to continue with the case studies. But before we take the case studies from the textbook of differential diagnosis, I want to open up the floor for discussions. I believe from what we agreed that participants will assess patients and try to see if there will be any case that will be identified that requires referral as a result of the systems review, trying to identify if there is any organic pathology that will require referral. So I think before we look at the case studies in the textbook, let's open the floor for the discussion in case there are some of the participants that were able to do that. So if you have any case to report or share with us, you can raise your virtual hand and we'll allow you to speak. Okay, it seems there is none, but I want to really emphasize that just having these trainings online, discussing theories, and reading out case studies of other clinicians is not going to really translate what we have learned into practice. We need to have practice-generated knowledge. For those that joined us in evidence-based practice, we discussed the three components of evidence-based practice: high-quality research, practice-generated knowledge, and patient preference and perspectives. So if we don't put this into practice, it's going to be difficult for the skills to be acquired. We will have the knowledge, but the skills will require seeing patients and applying this before the skills are acquired. And that is one of the reasons why, even though this is more or less like a practical class, we are still going to consider it as a theory class because of the issue of not being sure if the skills have been really acquired. The knowledge, certainly people have acquired knowledge, but the skills, I'm not sure. So, but let's continue. I'm going to share the first case study. So this is on gallbladder pain. Please, can someone help us read? Yes. Please let someone help read the case study. I think this does not have questions. Everything is just in the case that is reported.
Good evening, everyone. Good evening, sir.
Good evening, Jennifer. How are you?
Very well, sir.
Thank you.
Okay, so I read.
Okay.
A 48-year-old school teacher was admitted to the hospital following an episode of intense, sharp pain that started in the epigastric region and radiated around her thorax to the interscapular area. Her gallbladder had been removed 2 years ago, but she remarked that her current symptoms were exactly like a gallbladder attack. The client was referred to physical therapy for back care education on the day of discharge. On examination, the client was in acute distress, unable to tolerate a full examination. She had not been able to transfer to ambulate independently. She was instructed in relaxation and breathing techniques to reduce her extreme level of anxiety associated with pain, and given breathing techniques and given supportive reassurance. Instruction and assistance were provided in all transfers to minimize pain and maximize independent function. Given her discharge status, outpatient physical therapy was recommended for follow-up intervention. She returned to physical therapy as planned and was provided with a back care program. She was also treated locally for scar tissue. Symptomatic relief was obtained in the first 2 sessions without recurrence of symptoms. This case example is included to demonstrate how scar tissue associated with organ removal can reproduce visceral symptoms that are actually of musculoskeletal origin, the opposite concept of what is presented in this text. This may be more of an example of cellular memories sustaining a viscerosomatic reflex via the action of neuropeptides at the cellular level. Thank you. I'm done, sir.
Okay. Sorry, Jennifer, have you finished? A call just came in. I think you are reading the last statement when the call came in.
Yes.
Okay, wonderful. Thank you so much. So as I've said, this does not have question and answer. I think it's just trying to explain those symptoms that can come even after the removal, and why it's important to ask during the past medical history about, so patients comes to you, they have pain in one part of the body or another, asking about the past medical history or past surgical history will help you to be able to know if there was a gallbladder surgery. At least you'll be expecting symptoms like this, and you'll be able to explain what this is all about. So I think we'll not discuss this because there are no questions and answers. I will go to the next case study. And I think someone, is it Uchuku? Someone said they have submitted 2 case reports. I sent 2 cases. Yes, Chuks. Chuks, you can share with us. Dr. Jibril, if you have those case reports, please either share or send them to me so that I can share and we'll discuss them. Because it will be important for us to discuss something that is local, not just the ones that come from the textbooks.
Yes, I have shared it in the chat box.
Can you send to my WhatsApp?
Okay.
Send to my WhatsApp. So while he's doing that, I'm going to share another case. Okay, this is a case that's for GIT. Let me still share that. It's important for us to know what questions to ask to be able to know where the problem is from. So can someone read this? This is Crohn's disease and back pain. Can someone help us read?
Good evening, sir.
Yes, good evening,
everyone. Yes, sir. A 23-year-old ballet dancer with shin splits comes to you from a sport medicine doctor. Besides anterior lower leg pain, she also reports low back pain. that seems to come and go with overuse. She has a history of Crohn's disease. Can symptoms of anterior compartment syndrome be caused by Crohn's disease? It is very unlikely. There are no reported cases to date. Crohn's disease is linked with low back pain, hip, and sometimes knee pain. Knee pain is usually associated with hip pain and usually does not occur alone. Anterior compartment syndrome is easily reproducible with tenderness on palpation of the anterior tibial region. The pain pattern and etiology is fairly typical, and symptoms respond to treatment. If the soft tissues are acutely inflamed, surgical intervention may be required. What questions can you ask to rule out a gastrointestinal cause for a back pain?
Good. So can we discuss this? Let's answer the question. What questions can you ask to rule out a gastrointestinal GI cause for the back pain? Remember, we did GIT, and let's just go back to what we did, I think, on Saturday, either this last Saturday or the one before that. Any comments? What questions can we ask to rule out gastrointestinal cause for the back pain? Remember, we said GIT can refer pain to the low back. So there are parts of the GIT that can refer pain to the shoulder and other parts of the body. But since part of the GIT can refer pain to the back, how do we know that the pain in the back is not coming from the GIT? What sorts of questions do we ask? What will be the interpretation? And how do we rule out GIT? So if I don't see hands, I'm going to begin calling people as they appear on my participants list. Abdurrahman Halidu, you are the first on my list. Can you unmute? Just let us know one question you are going to ask. There are many questions, and we have them here in this document. Yes, Abdurrahman, just one question. What will you ask? Rahman, we can't hear you. If you can't speak, you send a message on the chat forum. Yes, send a message on the chat forum. Okay, I can see one of the case studies. Okay, that's fine. We'll come back to that. Adedayo Victor. Adedayo Victor. Next on my participant list. Abdurrahman, you can mute and send a message on the chat forum. Adedayo Victor, are you with us? Okay, Ademola Lajide. Ademola, am I alone on this platform? Or is it my network that's making people not to hear me? Please, if you can hear me, if you can't remember what we did, please just try to let us know. Just unmute and say you can't remember. We move to the next person. Okay, good. I'm not alone because I was wondering. Okay, does pain radiate to the lower back, lower limb? Okay, there's the pain, whether it's in the shoulder. Okay, so we are going to see if that's correct when we move to the answers. Okay, patient has ascites. Okay, we'll inquire if patient has ascites. Color of urine as a symptom. Okay. Okay. So let's just remember all these responses so that we'll have that metacognition. When we get to the answers, we'll then go back and see which of the responses are correct, which ones are not correct, so that we'll be able to now correct them when we do this in patients. Bowel changes, okay. Blood in stool, good. So blood in stool and bowel changes, okay. Yeah, so these are good ones. These are good ones. Let's see if there is any other response, and then we'll go to the answers. Is the pain altered by moving the painful area? Okay, is the pain altered by moving the painful area? So if it is altered by moving the painful area, I will assume what you mean is that it's a musculoskeletal, not the GIT. But the answer is saying, the question is saying, what questions do you ask to rule out the GIT? So what, if it's painful by moving the area, it is ruling in a musculoskeletal, just because it's the pain is altered by moving the painful area, it might not rule out the GIT. There still could be a GIT, a problem, possibly that's there together with the musculoskeletal. So ruling in musculoskeletal, yes, that's what I'm just saying. That just because you have ruled in musculoskeletal does not mean that there is no GIT problem. What is possible is that you have a musculoskeletal problem, therefore there is a direct pain in the back, but you can still have GIT problem that will refer pain to the back, and therefore you are going to have the pain as a result of the two underlying problems. So if you want to rule out the GIT, then you need to ask questions that are related to GIT. Yes, jaundice, itching, pruritus could be a question to ask. Wonderful. These are, well, let's see if all these are correct. So can someone help us read the answers? Yes,
Good
Mr.
evening,
Felix?
everyone.
Okay. Sorry, before you read the answer, I think Mr. Felix wants to, are you trying to add to what has been said, or are you trying to read? I can see your hand up.
Yes, sir. Yes, I want to add something there.
Okay, so go ahead.
I think we might also likely ask, does the patient experience no more pain maybe after hitting?
Okay, okay.
Does he have more pain after hitting?
After hitting, yes.
And no, yes, no. I want to know if the GIT is actually contributing to that pain or not,
Or not.
So I think that's another better question we need to ask him, Yes.
Okay, thank you. That's a good one. Okay, yes, please go ahead. I can't remember who started answering the question, reading the question. Okay, Ngozi, is it Ngozi?
Yes, good evening, class.
Okay, good evening. Yes, go ahead, please, Ngozi.
Okay, for the answer, ask about the presence of GI symptoms and signs and symptoms.
Yes.
Are you having any nausea, vomiting, diarrhea, or constipation? Any change in your bowel movements? Any trouble wiping yourself clean after a bowel movement? Any blood in the stool? Any other symptom of any kind? Headache, sweat, fever? Is there abdominal pain? And is it at the same level at the back pain? Does the abdominal and or back pain change with food intake?
Good.
Is there relief of back pain with passing gas or having a bowel movement? Is there a recent chronic history of antibiotics or NSAID use? Has the client experienced any joint pain anywhere else in the body? Any skin rash anywhere? A yes answer to any of these questions is a significant red flag and must be evaluated in context of the overall clinical presentation and finding from the review of systems.
It's good. So can we now look at it, at least the part that has been highlighted? Is there any of the things there that from the responses we had earlier that was correct? Can you just point out what we have here that was mentioned before we read the answer?
Blood in the stool.
Okay, blood in the stool. Is it on this page? Which item?
Is there?
Is there abdominal pain?
The fourth
Oh, any
line.
blood in the stools? Yes, this one. Okay,
Yes.
good. So that I remember that was mentioned.
Yes.
That was good. Is there any other thing that was mentioned?
Is there abdominal pain?
Then just
Okay, did someone ask if there was abdominal pain?
Food intake.
Someone
Someone
asked that?
said
After
issue of
food intake.
constipation.
Yes, I did.
I
did.
mentioned that
Wonderful,
one.
wonderful. Okay, that was on the chat forum, right? Okay,
Yes.
wonderful. Any other thing?
I also saw
Then I also
constipation.
mentioned the back pain.
Okay. Okay, back pain. Okay.
Is there back
So
pain?
can we
or-
now read out the ones that no one mentioned? Okay, let me go to the next part. Okay, is there anything here that was mentioned? The last few ones. So let's now read out
Does
the
the-
ones
does the
that
food intake
we not
no?
mentioned, because that's the metacognition thing. Yes, we can ask about bloating, of course, because it's GIT. Okay, can we just quickly read out the ones that were not mentioned? I know I don't think anyone mentioned nausea, vomiting,
No.
diarrhea, but
Nausea,
someone said
vomiting.
constipation was raised. Was
Yes.
constipation? Okay, so you can see nausea, vomiting are important things, diarrhea. So these are important things.
The
When
issue
we
of
are-
rashes was not raised. So.
Rashes, aha. Okay, but rashes, I think is down there. I want us to start from above. So any change in your bowel movements? Was there any question on changes in bowel movements?
Yes.
Okay, someone raised that?
Yes, I raised
Okay,
it. Yes.
okay, wonderful. Yes, I remember you
Raise
said
the
that.
hand.
Any trouble wiping yourself clean after a bowel movement? So when after defecation, it will be difficult wiping. This is a question also. I
Somebody
think
does
any blood in the stool, someone asked this.
Yes, sir.
Yes, any other symptoms of any kind? I don't think anyone raised this. Headaches, sweats, and fever. Because I remember we had this. If you have an infection, it will be in the GIT, but you will have constitutional symptoms. So that also is something important to ask. Is there abdominal pain? Yes, someone mentioned abdominal pain, but what was not mentioned was whether the abdominal pain is at the level of the low back pain. So that was missed. Does the abdominal and or back pain change with food intake? Did someone ask this?
No.
Yes, I
Yes,
answered that
yes,
no.
someone, yes, that was
I
Mr.
said
Felix,
that.
right? I remember you mentioned
Yes,
it.
yes, sir.
Yes. So is there relief of back pain with passing gas or having a bowel movement? Was there any question on this? Was there any answer?
No.
I don't think there was any. Yes. Is there a recent history of the antibiotic on NSAID? This also was not asked.
This was not.
Has the client experienced any joint pain anywhere else in the body? This was not asked.
No.
Any skin rashes?
Yes,
I don't think this was also asked. So can you see many of those things that are part of the checklist for GIT were not asked? I'm happy that there were a few that were mentioned, and that's good. So this is what metacognition is all about. I believe if I'm going to go back to the question and ask, we'll have more. So maybe let's try that. Let's see how many we can be able to bring up. Can we just quickly, because believe me, if you are giving a patient and you can't remember these things, unless you are going to go and pick your book and begin to read from the book and ask the patient, you are going to miss out. And unless you remember those symptoms and signs, you can't be able to know if you can rule out or rule in gastrointestinal system problem. So let's just quickly mention some of those things, and then we'll go back and see if there are still some that we have missed. So either on the chat forum, or you can just unmute and just speak. Let's quickly do that.
Okay, I just want to mention from what we've said now, we talked about is the patient, is there any abdominal pain? Is there the same level of the back pain?
Good.
Then is it affected by intake of food? Then is there nausea? Is there vomiting? Is there constipation?
Good.
Then we also said, is there bowel disturbances or changes? Also said whether there is a blood in the stool. We also talked about if there is a risk intake of antibiotic, use of NSAID.
Yes.
And we also talked about if there is any other musculoskeletal pain apart from the back pain. Then we also talked about if there are skin rashes. Then we also talked about if, I think that's what I can remember for now. Yeah.
Wonderful. Thank you. Wonderful. You have captured many. Anyone wants to add to what he has mentioned? Anyone? I think there are still a few that have not been stated. Anyone wants to add? Okay. So I think, thank you, Mr. Anuzi. I think you have touched on a number of them. So just look, because you are the only one that has mentioned, just look through and see which one is it that you have not stated. I believe you mentioned nausea, vomiting. You mentioned this ones. You mentioned change in bowel movements. I think you mentioned this. Blood in stool. Any other symptoms of any kind? That was the one that I did not get from the things that you said. The first thing you mentioned was the issue of abdominal pain at the level of the back pain. Does abdominal or back pain change with food intake? Can't remember if you mentioned this, but I think you did. Is there relief of back pain with passing gas? You didn't mention this. So when the person passes gas or bowel, whether the pain is relieved. Is there relief of back pain? Is there a recent, you mentioned this, the issue of NSAIDs. Has the client experienced any joint pain elsewhere in the body? This was not mentioned, but you mentioned any skin rashes. So can you see that after the metacognition, I think you only missed 2 or 3. But in the first instance, I think we missed more than 6. But now it's only 2 or 3 that you have missed. And if you do this over and over, whenever patients come, you'll remember almost everything. You will ask, and that will be the key to ruling in or ruling out, and also knowing whether there is any need for referral. So thank you so much. That's a wonderful one. I will share another one. Yes, I mean, is there any headaches, nausea, vomiting, constipation? Yes, that's good. Okay. Yes, Dr. Fine Achubwe, please go ahead. Before I share, you can go ahead and speak, please.
Yeah, good evening, my prof. I just want to ask a question. I don't know whether we can reserve questions when you finish, but I think the question what we just heard. I just want to ask this question. Must we have all of them as follow-up questions? Or if we have any 1 or 2 of them that we can remember, can that be enough of red flag that we can make use of and then make it better?
Okay.
I hope you understand my question, sir.
I do understand. If you remember the principle that we said about yellow flag and red flag, was that in yellow flag, usually you see either risk factors, where you only see a sign or a symptom, but that sign or symptom can be explained by other things apart from that organic pathology. So that is going to be a yellow flag. You don't just refer, you continue with further questions until you establish that there is a yellow flag, but that there is a red flag. But when it comes to red flag, usually it comes either with combination of risk factors and symptoms. But another thing that's important, that you need to have a red flag for one of the systems of the body. But whenever you have a red flag that shows an organic pathology. For example, the constitutional symptoms. There is fever, there are chills, and one or the two other things that really indicate that this is an organic pathology. You refer. But then, if in your institution you only refer to physicians, that's easy. You know that's an organic pathology, refer to the physician. But if you can refer to a specialist, then you need to have further questions that will indicate from what system that problem is. For example, someone that has fever and chills, you wouldn't know from what system. It can be the neurological system, it can be the GIT, it can be the urinary system, it can be anything. Now, these questions that we just discussed now are the ones that are going to help now to say that, look, from the questions, there are one or two that indicate there is a problem in the GIT. Now, the fact that I see constitutional symptoms, this is an organic pathology, and those one or two or three questions that indicate there is a GIT problem, this will indicate a referral to the gastroenterologist. So these are some of the issues. You don't have to have all of them, but what constitutes a red flag? You'll have to go back to the slides. It is in the slides that it shows what combination of risk factor symptoms and signs give a red flag and what combination gives a yellow flag. If you don't have a combination of a red flag, but you have at least one in all this that we have listed, then you will have a yellow flag. You will need now to add more that gives a combination of a red flag before you refer. But just seeing one, if it is not indicating an organic pathology, you might not refer. It will be a yellow flag. You will need to ask more questions. So I hope that helps.
Yes, thank you very much.
Yes. Thank you. So can we have someone reading this? This is abdominal and back pain at the same level. Remember in the earlier one, we discussed the issue of having pain at the same level between the abdominal and the back pain. So can someone help read this?
Yeah, I want to read.
Okay, go ahead.
Yeah. A 68-year-old accountant came to physical therapy as a self-referrer for low back pain. He reported sleeping on a patch of ice as the mechanism of injury. Symptoms were mild but distressing to this gentleman. He reported pain as sore and aching with any spinal twisting or side bending to the right. The pain was present across the low back on both sides. The client reported symptoms of stomach distress from time to time. He attributed this to his trips overseas, eating food from Ireland, Scotland, Germany, and Netherlands. Lumbar range of motion, RM, was fairly typical of a nearly 70-year-old man, with most of his functional forward flexion from the hips and thoracic spine. True physiological motions in the lumbar spine was negligible. Accessory spinal movement were also limited globally. Active rotation and side bending were stiff and limited to both sides, but only painful to the right. Neurologic screening exam was negative. The therapist did not ask about the presence of any other symptoms of any kind anywhere else in his body. No questions were asked about changes in the patterns of his bowel movement or appearance of his stools. Given the examination results as tested, a conditioning exercise program seemed most appropriate. The client began a stationary bicycling program, alternating with walking when the weather permitted. He reported gradual relief from his symptoms and return of motions and function to his previous level. 4 months later, this same client reported another injury while walking with subsequent back pain. Can you leave it? Okay, all right.
Yes,
What
read the question.
Okay, question. What are the red flags findings? What is the next step in the screening process?
Wonderful. Thank you so much, sir. So let's look at the case report. I'm just trying to make sure that we have the whole, maybe it might be too small, but so that we can be able to look at the whole picture. I hope that's helping. Yes, so what can we answer the questions? What are the red flags? And what is the next step in the screening process? Any comments? I think I've seen interesting things there that we can be able to make comments on. Any comment? Okay, I can see a message on the chat forum. Age of the patient. So, okay, how old? 70-year-old. Okay. So age of the patient, but age of the patient alone is a cause for concern. It's a yellow flag, but it doesn't tell us that this patient has a GIT problem or a musculoskeletal problem or any other system problem. But I agree with you strongly. The age 70 years old is a yellow flag. So any other comment, any other issue about red flags? Yes, GI problem reported, but wasn't specific though. Okay, so what was the GI? Yes, I think he mentioned, but he attributed this to eating because he kept traveling from one country to another. So possibly he thought it was just because of the food, and the physical therapist did not bother to ask further questions. So that's a very good one. Did not ask further questions to know whether it is just as a result of moving around from country to country, eating different foods, or whether there is truly an organic pathology that is coming from the GIT. Yes, very, very good. Stomach upset, yes, he mentioned that. He mentioned that, but there was no follow-up. And I think that's one of the problems with this case. The GI symptoms should be further defined. Exactly. It should be further defined, not just the patient reporting and you make assumptions that it is because of the travels. The fall should be further evaluated. Yes. Why did the patient fall? Why did the patient fall? Okay, any other thing? So what are the red flags and what is the next thing to do? What's the next step in the screening process? Is this a case for referral or is it a case that requires further investigations? The recurrent episode of the pain. Yes. Okay, so it keeps coming. Why does it keep coming? We need to find out. Why does it keep coming? The nature of the pain. Yes. So now we are asking, is this a case for referral or is it a yellow flag that we need to further investigate? So I'll just get that answer and then we'll move. Yellow flag. Okay. So yellow flag. So let's see. Can someone help? There's a need for referral. Okay. So we have two yellow flag that needs further investigation. So we have two people saying yellow flag. We have one person saying red flag. So let's read the answer and let's see which one is correct. Can someone help read the answer? Anyone wants to volunteer?
The client's
Yes,
age
okay.
over 50 is the first red flag. Back pain across both sides can be considered bilateral and therefore a red flag until further assessment is completed. The presence of back pain and abdominal pain or discomfort warrants some additional questions. Therapists should conduct a more thorough pain assessment and ask about the location of the symptoms as well as the presence of any additional gastrointestinal symptoms. Back pain and abdominal pain at the same level is always a red flag. Screening questions related to the back and the GI dysfunction are available at the end of this chapter. Questions about changes in bowel function may reveal some important clues. A screening physical assessment of the abdomen, including visual inspection, palpation, An auscultation as described in Chapter 4 may be helpful. Vital sign assessment is always recommended. The key red flag in this case was alternating back and abdominal pain at the same level. The client did not see a connection between these two episodes of pain. When his back hurt, he did not have any abdominal pain and vice versa. The client was advised to see his regular physician for an evaluation. He was diagnosed with colon cancer in advanced stages and died 6 weeks later. Earlier detection may have made a difference in this case, but the cyclical nature of this presentation, of his presentation, marks the true significance of his symptoms.
Thank you.
Yeah.
That's just that book, Differential Diagnosis, that we have been picking these cases from. So can you see many interesting things? Those things that we listed, that's the one they are referring to. I think they said in a particular chapter, or is it chapter 4, that you can see those questions that you can ask. But these are the things that we asked in the last case that we read. But there are additions here. Remember, in the last case, we did not mention the issues of visual inspection, palpation, and auscultation. And when we did this on Saturday, we saw even how to do the palpation, what do you feel, and the auscultation, what do you feel, and what the interpretation is. So these are additions when it comes to GI. The physical therapist did not ask many of these things, did not do many of these things, and at the end of the day, they missed that opportunity to see a red flag that requires referral. They did not refer on time. By the time they referred, it was late. There was a diagnosis of an organic pathology, which was the colon cancer, and the patient died six weeks after the diagnosis. So there are many important things here to take note of with our patients. Very important when we see when they keep saying red flag here. Remember, we talked about the age is a red flag, but this red flag is not a red flag for referral. I still feel it should have been a yellow flag, because just because of the age, in fact, when you read further, they will say warrant some additional questions. It warrants some additional questions. If red flag here, as it is, means it's an emergency, there should be a referral, then they will not be asking for additional questions. And so at the point that you see an emergency, it requires referral, and then that is when that red flag, as we defined it earlier, will be. But the way I look at this red flag is still a yellow flag, not a red flag. Let me read from the comments. I can see a number of comments coming in. There's also a temptation to miss systems review when there's traumatic etiology. Very true, very true. But the issue is that it's even possible the trauma could have affected organs. And therefore, just having trauma and the patient has a fracture or they have an open injury, we shouldn't just assume that, well, this is a musculoskeletal problem, and therefore there is no need to do systems review. In fact, that should be a very good reason to even review the system because of the trauma. So because of the presence of risk factors and symptoms, yes, if there are risk factors and symptoms together, then it's possible it can be a red flag. But the interpretation should determine whether there is a red flag and whether the red flag is for a particular system. These are also very important things to take note of. Yes, so thank you very much. I think we are going to go to the next one, or maybe at this point, let me see if I can share the case that was reported here. I think it's always important for us to go back home and see what's relevant to our practice. So I'm just going to copy and paste it in a Word document, and then I will share it. So when I share, I think it will be best if Mr. Uchubu will be the one to read this your case, and so that you check us through. You might give further explanations because you saw the patient. Yes. So if you are with us, please go ahead.
Hello, sir.
Hello, yes, go ahead. Go ahead.
Thank you. So these are case studies for this. Okay. So case A. This a case that occurred in my early years of clinical practice in early 2001. Occurrence was in a private clinic, well reputable. Patient was referred to me by female senior medical colleague, which I must say treated me with respect and professionalism. History from patient was that it was that of pain and discomfort that wasn't relieved by drug. So history from patient was that of pain and discomfort that wasn't relieved by drugs. Does not allow him to sleep deeply, or was afraid his weight is more or less, that his weight more or less remained the same despite his heavy appetite. Also, that pain was in the region of right shoulder and the cervical region. Patient wishes that I find cure to his lack of sleep, pain, and find why his weight is increasing despite his large appetite. Patient was male, mid-30, was employed, and a marketer and single Nigerian.
Good. Thank you very much. Truly, truly appreciate you for the effort to come up with something. Well, that's Mr. Oche, right? Thank you very much. I must commend you because we need to start applying these things on our patient. Even though I see that it is an old case, but nonetheless, at least you are able to bring something that is local to us. Now, let's discuss this. What?
Only one that brought this case, sir.
Oh, it's not you. Yes, I
No.
remember it was Mr. Iwuchukwu. That's why I was saying let him read it so that he can give us some explanation. But it doesn't matter. All the cases that we read from the book, the authors are not with us, and we read them and we discussed them. So I think that's very okay.
I'm sorry.
That's all right. Let us go ahead and discuss. What do you think? Are there red flags here? Or is it only yellow flags?
Sorry, Prof. Okay.
Yes, ma'am.
Sorry, sir. Before we go on, I think that second to the last line should be corrected. That the pain and find why his weight was decreasing instead of increasing that is there, despite his large appetite. Because the report that was for I think line something. Let me see. There is a line that is saying that despite his large appetite, that there was no that the weight is more or less remain the same despite his heavy appetite. But here he said the weight is increasing despite the heavy appetite. Heavy appetite is supposed to increase the weight. So I feel that there's something wrong in that report. We should correct it.
So that's a good one. That's something also that is important. If Iwuchukwu is with us, he can give us clarification as to which one is correct. Weight loss despite eating well. Okay. Red flag. Okay. So weight loss despite eating well. So this is someone said it's a red flag. There is weight loss, but the person is eating well. So meaning there is something that is leading to the weight loss. So okay. Any other issue? Okay, someone said lack of sleep and weight loss. So I think that weight loss is really an issue in this particular case. I think any age above 50 and weight loss, I think, okay, should be a red flag. Okay, any age above 50. Yes. But what I was saying earlier was that just because someone is above 50, who do you refer him to? So that was the issue I was raising. It's a yellow flag, or it could be a red flag, but a red flag for what? Who do we refer to? And that's one of the things. If you just refer a patient that's 50 years and above to a physician, I said, I'm referring to you because I know this patient must have organic pathology. Then you are going to have trouble with them. So for me, even though they keep calling it a red flag, I will still see it as a yellow flag that is over 50. Let me ask more questions so that I will see if there is a red flag that indicates that there is an organic pathology. It's not every 50-year-old patient that will have an organic pathology. I still insist that I will see it as a yellow flag and ask more questions rather than see it as an emergency and just quickly ask the patient to go to a physician. Yes, go ahead. Yes, go ahead. I'm listening.
Please, Prof, where is the pain? Where is the location of the pain?
Okay, so sorry, can we go by one after the other? I think someone is speaking.
That the patient is mid-30, not 50.
Okay, maybe that case was the old one. I think that case was an old case that I just was reading through. I think it is the last case report. So let's not bother about the age now. Okay, yes, Ma, you are asking about where exactly was the pain?
Yes, Prof.
Also that the pain was in the region of right shoulder and the cervical region. Does that answer that, or is there another place where it was mentioned that there is pain and we can't be able to trace what type of pain?
Okay. I just want to be sure whether that's because it talks about what type of pain.
Yes.
Pain.
It talks about the right shoulder and the cervical
pain that
region.
wasn't released by drugs. Okay, thank you, Prof.
Okay. Now, is there anyone that can let us know, is this case a yellow flag or a red flag that will require referral? That's the first question that I will ask. Then I will ask follow-up question.
Prof, can I speak?
Yes, go ahead, please.
Yeah, because of the unexplained weight loss, that's the red flag for me.
Okay.
Yeah, despite the the appetite that is okay, that there's unexplained weight loss. You can't really tie it down to something. Even though there is insomnia, but insomnia, I'm trying to think that it's likely to maybe related to the constant pain. So I want to explore the pain more. What's the level of pain? I want to rate the pain and see whether it's more mild, moderate, or severe. And I want to find out if there are aggravating factors. Is it relieved at any point of the day? Is it nocturnal that is affecting the sleep, or is it aggravated by something? Then the pain is located at the cervical region and the right shoulder. I want to explore more on that cervical pain. I want to find out.
It's on the bed that you're not fall asleep.
I want to find out. He's a marketer, so I'm looking at the biomechanics now. Is it affecting? Is it because it sits on the system or not? No. So because of the pain it's having on the cervical region and it's having shoulder pain at the same time, and I want to explore that shoulder pain more. I want to find out if there is also pain. Maybe I want to find out when he's eating, is there any pattern of pain that is he reproduced when he eats? I want to find out that. I also want to do a lot of vital signs to find out if there are changes there, because we've done a lot of we've done a lot of systems review, and we're able to find out that there could be a referral of pain from the cardiac origin to the heart. We can also even from the lungs to the heart. So I'm seeing red flags for possible cancer. I'm thinking this patient may even be screened for a possible cancer. Then I also want to find out if there is fever, there is chills. I want to ask all those systemic questions. I think let me stop here so that people can contribute.
Okay. Yeah. Wonderful. I like the fact that you mentioned cancer. If you go back to the slides that we looked at, some of the issues raised here are part of the red flags for cancer. Some of those that are presented here. But of course, we can also, that's the next question that I would have asked. Say, what will be the source? Now, apart from cancer, what other system of the body, or what system of the body can you implicate? Or do you want to say, okay, let me ask more questions to rule out or rule in that particular system of the body? What other system?
In fact, what the first thing I will look at there is the pulmonary implication. It could be TB of the lungs too. It could be tuberculosis because of the regular loss of weight despite that the appetite is good. So when we look at the lungs, when we look at the heart and see whether the patient has TB or is cancer, as has earlier been said.
And I agree with you too, because the pulmonary system can refer pain to the shoulder. We know that. Of course, I know looking at the cervical spine, that may not explain that, but at least the shoulder is mentioned, and pulmonary can send pain there, and the issue of weight loss, you have linked it, so that's good. I can see another suggestion, hepatic system. Yes, two people are mentioning hepatic system. The hepatic system also refer pain to the shoulder. And the issues that have to do with weight loss, also we see those symptoms across systems of the body. So this is wonderful. Now, what do we need to do? What we need to do here is to now pick each of those systems that we suspect and ask more questions there to be able to now see if there is a red flag for that symptom, and then we'll refer. So we'll go back to the slides and see what are the red flags that means there is an emergency for oncological issues, for pulmonary issues, and for hepatic and biliary, and also GIT. Because when you talk of weight loss, even though there is appetite and the patient eats well, all these systems can be implicated. But then follow-up questions to establish red flag in any of these four will be very important. So wonderful. Thank you so much, Iwuchukwu, once again. Do we still need to take the second? I think the second one is not complete, so we're not going to take it. Case B is not complete. Yes. Yes.
Prof.
Yes, go ahead.
I actually sent
Iwuchukwu, before you comment, let's Dr. Oyeles please complete his statement.
Because right from the previous explaining we learned from the slide, because pain in the right shoulder could be a refer pain. And we also be thinking of probably the kidney is inflamed and is touching the diaphragm and back to the shoulder. We should also ask questions in relation to
the urinary system.
Urinary system too.
Exactly. Exactly. That's another good one. Anything that could explain where the patient has the symptoms they have, very true. So ask about urination, color of the urine, the frequency, and all those things that will indicate a problem coming from the urinary system. Yes, Mr. Iwuchukwu, please go ahead. It is your case we have been discussing. Yes, so you have the floor.
Yes, this case is long, but it made an impression on me because it's the way it is. There's no other thing. But what bothered me is the way he was complaining. He was eating and it wasn't showing. Okay, so I personally, that time I was fresh, so I didn't know what to do. So I quickly went for X-ray. X-ray. Because the doctor has said, okay, he's has pushed the case to me. So I went for X-ray, and behold, I saw a TB spine pus. Okay, so I went a confirmatory test and Mantos test, and it was positive. So it was TB spine that the patient had.
See, Mr. Iwuchukwu have brought us now to another system completely. And that's the interesting thing. And I think what really excites me here is the fact that you don't just, that's why the last person that said, let's think of the kidney. I said, urinary system. I said, very important, let's go there. So can you see that it's inexhaustive? You can't just think of only 2, 3, or 4 and say, that's it. Then the patient may have it in another system that you have not considered. So that is why systems review, you have to consider all the systems, all of them. Thank you so much. Now you have solved our problem, that the problem is not even from the cancer that we thought, or the pulmonary system. The TB, you said, is it of the spine or the pulmonary system? The spine, yes, TB of the spine. Yes. Exactly. Okay, so that's a good one. That's a good one. Anyone wants to make any comments, at least on this new revelation?
Yes, Prof, I just want to talk about even if it was TB spine, usually it would start from the pulmonary origin. Okay. So I think we're still in line to do that pulmonary review before it gets to the spine. Yes. Yeah.
Okay. That's a good one. But thank you.
Yes, okay. Yes, sir. I think other signs and symptoms that will confirm the TB also should be investigated. Was there any a history of night sweats? And was there any gibbous at the back? Did we examine the spine and we see that there is gibbous there? Or is it early stage of TB spine? Was there pain on the back? Because that was not reported in the history capture. Was there any back pain at the thoracic region, or at what level?
Discomfort, and he couldn't sleep.
Discomfort
the pain,
at where?
The pain was saying in the cervical region. That's why it was a bit complicated.
And for the mere fact that it's TB spine, it can affect any joint, it can affect any level. TB spine is not limited to the low back alone or to the thoracic back.
Yes, let's have Dr. Fine. Dr. Fine Achubwe.
I want to know the outcome of the treatment of these patients, if you can tell us what was the finding. The reason why I asked this question because I want to know the link of weight loss. Has to do with TB of the spine, because I know that this symptom is a cancer symptom.
Well, weight loss probably can be associated with more conditions than just cancer.
Yes.
Even associated with even the TB of the spine. Yes.
Unexplained weight loss is one of the cardinal symptoms.
Yeah. He said weight loss is one of the cardinal symptoms.
Yes.
Of TB.
Yes.
Okay. Of TB, yes.
Hello, sir.
Yes. Hello, go ahead. Yes, go ahead, ma.
Weight loss is a cardinal symptom in TB. Very important symptom. And we can see that in this patient, there was no report of cough. So there's no pulmonary, there's probably no pulmonary. So I think other joints should also be investigated further. This pain he has at the shoulder and the cervical spine, those areas should be investigated for, because the TB can actually spread to the joints.
Yes.
So it also looks like cancer, but it's not impossible that this patient can have cancer. But I think further investigation will
reveal that. One thing that's important is for us to know that you can have more than one underlying disease. It's very possible. Yes, either they are associated or they are not associated. It's possible that you can have a patient that has more than one underlying diseases, and that is why it's important that we have, just because we have identified one and it can explain the other, we don't assume that it is the cause of the other. We go ahead and make our investigations to rule out others that are not associated with it. Very important. So this wonderful. Thank you so much to everyone. very, very great.
Sorry, sir. Before we conclude that, I
Yes,
just
ma'am.
want to chip in another thing.
Okay,
That
sure.
TB has many focal points in the body. It can even affect the GIT. I've managed a case before of TB of the GIT. It was difficult for them to diagnose, but eventually, and for the mere fact that the mantle test was positive, it's giving us like 90% assurance that TB might be one of the conditions that will be implicated.
Good. Thank you very much. So I think key here, from all that we have discussed, risk factors, symptoms, and signs of diseases. Very important. But at the same time, we need to also understand that we are not ruling in or ruling out organic pathology from the perspective of a condition. That's not what we are doing. So this particular case, TB spine, we are mentioning TB spine because I don't think it was the physiotherapist that made the diagnosis of the TB spine. At some point, what is expected is to say there is an infection coming from the neurological system. For example, might be TB spine, might not be TB spine. It is the referral and the physician that is going to now diagnose the condition, so that we don't go and now make a referral. We say that I've done multi-sex, I've done this, I've done that. At the end of the day, I've found out that this patient has TB of the spine. I want you to take over and manage. That would not be a proper referral. Our referrals should not indicate what the medical diagnosis is, because we are not trained to make medical diagnosis. We are trained to make physical diagnosis. But we are trained to suspect that there is an organic pathology in the system, and then we now put in our findings and refer and allow the physician to make the medical diagnosis, because that is within their purview. So this is just to add this. But all in all, I'm happy with the discussions. I'm also happy that Mr. Chukwuka has saved us by giving us a case that is local, not the ones that we have been reading from the United States. Thank you so much, Mr. Uchuku. Thank you to all those that have contributed. So I'm going to share another one. So maybe we'll go to another system. I think we have taken GIT and we also took gallbladder. So let's see if we can take another system. Okay, we'll look at the urological system now. I can see a hand. Before we start to read, I'm going to find out probably why constitutional signs of pulmonary TB like cough and night sweats were not present. Okay, yeah, sure. I think we have already mentioned that there were no, but I don't think the patient was asked, do you have cough? Do you have night sweats? Do you have that? So very important to ask those things to rule out pulmonary system problem. So can someone help us read this? Let me see. Okay, it has answers. So let's read this, please. This is screening in the presence of risk factors for kidney disease.
African American.
Sorry, let me just realign. Yeah, sure. Go ahead.
Can I go ahead, sir?
Yes, go ahead. Go ahead. We are listening.
A 66-year-old African American woman with a personal history of systemic lupus, erythromycin, lost her balance and fell off the deck at her home. She sustained vertebral and rib fracture at T10 until 11. She is a retired paint factory worker. She reported daily exposure to pain and paint solvent during her 15 years of employment.
Sorry, before you go further, I think this is part of what we took earlier, right? Do you still want us to go ahead? Yes. Do you want us to still go ahead, or should I share?
We have looked at this before.
Yeah, we have seen this. So let me share another one. I think I randomly picked this when we were doing the class the other time. So let me just share another one that we have not done. I don't think we looked at, okay, we have not looked at this one. And I'm going to hide what is it about so that we'll be able to identify it ourselves. Yes, so can someone help read? Maybe there's some person that was reading the other one. If you can help read this one.
Can I go ahead, sir?
Yes, go ahead.
Right. A 55-year-old woman came to the clinic with back pain associated with paraspinal modules, spasm. Pain was of unknown cause, insidious onset, and the client reported that she was just getting out of bed. When the pain started, the pain was described as a dull aching that was aggravated by movement and relieved by rest, musculoskeletal pattern. No numbness, tingling, or shadow anesthesia was reported, and the neurologic screening examination was negative. Sacroiliac test was negative as well. Spinal movements were slow and guided with muscle spasm noted throughout movement and at rest. Because of our age and the insidious onset of symptoms, further questions were initiated to screen for medical disease. This client was mid-menopausal and was not taking any hormone replacement therapy, HRT. She had a bladder infection a month ago that was treated with antibiotics. Tests for this were negative when she was evaluated and referred by a physician for back pain 2 weeks ago. She had an upper respiratory infection, a cold, and had been coughing a lot. There was no previous history of cancer. Local treatment to reduce paraspinal muscle spasm was initiated, but the client did not respond as expected over the course of 5 treatment sessions. Because of our recent history of upper respiratory and bladder infection, questions were repeated related to the presence of constitutional symptoms and changes in bladder function and urine color. Cause of stream, burning, urination, and so on, occasional sweat, present sometimes during the day, sometimes at the night, was reported.
Good. What is the question?
Now the question is, what are the red flags to suggest medical referral is needed?
Good, wonderful. Thank you so much. So, can we look at this case? What are the red flags? Trying to see if I can reduce it to show the whole. Aha, yes. What are the red flags in this case that could indicate need for referral?
Prof.
Yes.
The red flags I can see, of course, history of sweating a lot. Sweating, yeah, and that's the upper of has to do with upper respiratory infections.
Okay, your network isn't strong.
I'm saying the pause when it's issue of sweating in the night.
Yes. Okay, sweating in the night. Okay.
Yeah, and then issue of infection, upper respiratory tract infections, and as
okay. Thank you. Yes, Okibo Callistus. Yes, I can see someone posting pain of unknown cause, upper respiratory and urinary infections and night sweats. Yes, that's a good one. Yes, go ahead.
Also RH, sir. RH and postmenopausal syndrome also.
Okay.
It can be implicated. So we can manage it at our level. We should refer.
Okay. So no response to treatment.
Also
okay. Yes, okay, but go ahead.
I want to talk about the.
No, Dr. Fine. Let Mr. Callistus.
Also, there was a history of cough. He said 2 weeks ago.
Exactly. Okay. Good. Okay. Yes, Dr. Fine, go ahead.
One of the things that can for referral is that movement, pain or movement, and then resting. And that can suggest an organic condition or pathology.
Thank you. Another person posting age, unknown pain, coughing a lot. Yes. Nature of the pain, night sweating, history of cough, urinary infection. Wonderful. So, okay, these are all very good responses. Let's read the answer. Yes, can someone help read the answer?
Yes, sir.
Yes, go ahead.
The client did not return to the clinic for further treatment.
No, sorry, I think there's something before that, the combination of recent infection. I think that's the answer. Instead of question, it's supposed to be answer, and then they put question. So just read from that.
The combination of the recent infection, failure to respond to treatment, and the presence of sweat raised the red flags, and suggested referral to the physician for early reevaluation.
So see, I'm going to give all of you one big bossa, because all the things that you mentioned are the ones that are in the answer. I had recent infection, I had failure to respond to treatment, and presence of sweats. I had all those from your responses. Wonderful. See, you have covered all that they have here in the answers. Thank you. Yes, go ahead.
Results. The client did not return to the clinic for further treatment, and a follow-up telephone call indicated that she did indeed have a recurrent bladder infection that was treated successfully with a different antibiotic. Her pain and muscle spasm were eliminated after only 24 hours of taking this new antibiotic.
So can you see those questions had helped for her to be treated correctly? If you have continued to give her exercise and short of diatomy, the pain will relieve, she will go home, she will come back, and it will not. But look at it. The appropriate treatment, because the pain was being referred from the kidney, the treatment of the kidney has made the back pain and the muscle spasm disappear within 24 hours. So very important. If there is an organic pathology, don't continue to treat the patient. They are not going to eliminate the source of the problem. They will only be having relief of the symptoms. Sometimes, look at the case. It said it wasn't even responding to treatment. So our treatment is not really going to be even any useful to the patient, because the source is not movement impairment. The source is organic pathology. This is another very educative one. Thank you. So let me share another one. Okay. This is not long, so we'll share this. Let me also hide what it is about so that someone will let us know what system it's related to. Yes, so can someone help us read?
A 66-year-old man with low back pain was evaluated by a female physical therapist, but treated by a male physical therapist. By the end of the third section, the client reported some improvement in his painful symptoms during the second week. There was no improvement and even a possible slight setback. During the treatment section, he commented to the aide that he is impotent.
I think we have taken this case.
Yes, we've taken this one.
We took this case, exactly.
Yes, yes, sir.
I can't remember what happened, but I know we took this case, so we'll jump that.
We did.
Yes. Thank you. So let me share another one. Okay. This is something similar, but I don't think we have shared it. So let me share that. Okay. Can someone help read?
Can I go ahead?
Yes, go ahead. Is it let me see. Is it Abdullah Walker?
Yes, sir.
Can someone let's at least have many people attempt. I think you have read one before this one, right?
Let me go ahead and read this one.
Wonderful. Okay, go ahead, Mr. Preston. Yes.
A 20-year-old track star and college football player developed back
Okay, Christian, are you with us? Was the network kicked you
buttock
out?
and post-football injury to physical therapy by the team physical L5 radiculopathy. Please treat using McKenzie exercise program. During the physical therapy interview, the client reported left low back pain and left buttock pain present for the last 2 weeks after being tackled from the right side in a football game. Symptoms developed approximately 12 hours after injury. Pain was always present, but was worse after sitting and better after standing. On examination, the client presented with major losses of lumbar spine range of motion, lateral shift, and lumbar lordosis was not excessive or reduced. Overall postural assessment was unremarkable. He was able to lie flat in the prone position and perform small prone press up without increasing any of his symptoms, but he described feeling a hard knot in my stomach. While in this position, upon palpation, the therapist felt a small mass in the left upper abdominal region. When asked if he had any symptoms of any kind anywhere else in his body, the client replied that right after the injury, his left testicles swelled up but seemed better now. He denied any blood in the urine or difficult urinating. Vital signs were within normal limits. The client was given an appropriate self-treatment program to perform throughout the day with instruction for self-assessment of his condition. Question: what is your keep/referral decision? Explain your rationale.
Good. Thank you very much. Can we look at the case?
Rationale. Thank you.
Okay, thank you. So, any answers?
I think the abdominal mass observed, and the fact that the pain is not affected by movement, all the spinal movement did not have effect on the pain, but its own ears. So that shows that it may not be of musculoskeletal origin. But palpating that mass is enough red flag to refer.
Okay, that's good. Okay, any other comment?
History of testicular swelling.
Yes, his left testicle swelled up. Exactly. Okay. Any other thing?
And also the blood in urine.
Yes. Okay. No, I think it says there was no blood in the urine,
Not
isn't
report any blood in the urine.
Yes.
Okay,
Exactly.
he denied it. Okay.
Yes, he said there was no blood in the urine.
Testicular injury is.
Yes, there was a testicular affectation. At least it swelled up. So what do we think? Is this a case that should be referred? Is there enough to say that it's a red flag that we should refer?
The mass.
Yes.
What I want to
and
add,
then the abdominal symptom, you know, when he's describing having a hard knot in his stomach.
Okay. So do you think that is a basis for referral? Or is it a case that we need to ask more questions?
To have that knot defined, the mass of the stomach defined.
the pain was always.
Can I?
Yes, one after the other, please. Can we? Okay, sorry. Okay, Mr. Felix, go ahead. Go ahead, Mr. Felix.
Yes, sir. So I think the question asks the question is in two formats. You know, your rationale for keeping or referring, you know, these patients. Yes. So I think it's in two dimensions. You have reason to keep this patient and also reason to refer the patients. You know, because at a point you can say that okay, this pain response to changes in movement. So that shows a form of some level of musculoskeletal challenges that this client is having, which might respond to some of our modalities, of treatment. Then the other pathology, that could be noticed easily, from the case at hand. We could see that, at a point that I think they mentioned issue of discovering a mass or so. Let me see. At the abdomen. Okay, yes, first is small mass at the left upper abdominal region. When asked if he had no symptoms of any kind anywhere else in the body. So that could also be a case for referral, and also having the left testicle sweat up. Something must have gone wrong, either an infection or is there any trauma to that testis, in the time past that could have led to that. So we need to also find out about that. So that also can be a cause for referral. So and also let me see. I think but let me stop at that point, sir.
Okay.
So we have more places for keeping this patient, also referring the patients. So it's in two dimensions. Thank you, sir.
Thank you. Well done. Okay. Any other comment? I heard many voices at some point at the same time. Yeah. Okay. Okay.
My own comment about the aspect of our intervention. When you see a bigger problem, it's better you address it first than say we should keep because of the musculoskeletal pain. That's just my own.
I actually think that this patient should be referred for further investigation.
Actually,
before any intervention can continue by the physiotherapist.
I think sometimes we make a mistake that we think because there is an organic pathology that we can't treat the patient. So when we say keep and refer, what it means is that as you refer the patient, he sees the physician, he can come back to you. And then you see the case that's a physical therapy case. So I don't think there is any physician related problem that would be more important than the one that you are going to treat. So it all depends on what the situation is. I think it's still possible that you have cases like this, you refer, they ask them go and do tests, take this drug, and then they come back to you. So it's not that they don't go. When they say keep a refer, if it is only a refer case, what it means if they go, they don't have to come back to you. When you keep them and it's not a referral case, it means they are not going to go anywhere. They will keep coming to you. When you say keep a refer, it means they will go get the diagnosis today. Tomorrow they take their drugs. By tomorrow evening or after 2 days, they come back to you. That also is a keep and refer. So I think we need to understand that concept. It doesn't mean that they are not going, they must stay. No, it means they will go and get attention there, maybe today or tomorrow or next week, but they will still be coming to you for what, unless if there is a contraindication to the physical therapy interventions that you give. Then in that case, they don't stay, they just go. So just to clarify that. So, okay, this is wonderful. I think we have gotten many comments. Can we read answer? Yes. Yes, go ahead.
Yeah, sir.
Yes, go ahead.
Yes, I agree with you very seriously that we need to keep patients and then refer. Not all the time we just say, okay, let's just even consensus will not even handle it. So it depends, actually, as I said. So in this case, for me, I would say we should keep the patient and then also make the therapy.
Thank you. Thank you very much. So let's see what the answer is in the document. Can someone help read?
Okay. I read. Even though the therapist thought the clinical finding supported a diagnosis of derangement syndrome according to the McKinsey classification, there were enough red flags to warrant further investigation. The therapist contacted the physician with the following concerns. 1. Palpable, non-pulsatile abdominal mass in the left upper abdominal quadrant, anterior. Reported left testicular swelling. Age. No imaging studies were done to confirm a disc lesion as the underlying cause of the symptoms. Results. Physical referral was made after a telephone discussion. Okay, physician referral. Thank you. Physician referral was made after a telephone discussion outlining the additional finding listed above. An abdominal CT scan showed pressing on nerves as the cause of the back pain. Further diagnostic testing revealed testicular cancer as the primary diagnosis, with metastasis to the abdomen, causing the abdominal mass. Surgery was performed to remove the testicle. The back pain was relieved within 3 days of starting chemotherapy. Physical therapy was discontinued for back pain, but a new plan of care was established for exercise during cancer treatment. Thank you.
Wonderful, wonderful. Another big bossa to our team. I remember you mentioned as part of the red flags, palpable abdominal mass. You mentioned left testicular swelling. I'm not sure if age was mentioned, but at least we have age here. And these were the issues that were raised. And a referral sent back to the physician and see what was diagnosed. And remember, it was the same, it was a physician that sent the case to the physiotherapist. But the physician did not take note of all these things that the physical therapist noted. And then the physical therapist now wrote back. And because of what the physical therapist noted through systems review, the diagnosis was made and the patient was put on treatment. So very interesting one. Any comment before we go to the next one?
Good evening. Hello, Prof.
Yes, go ahead.
Yeah, I like the comment you made because I actually wanted to raise this concern in the previous case where we talked about the person with the GIT and urinary tract infection. Because in that case, that patient was referred for back care management by a physician, and then still had to refer, or the therapist had to refer that patient back to the physician. And that was when they realized that the treatment wasn't well done previously. And here again, we're raising this concern of having a patient sent from someone, the therapist had to send back the same patient. My concern here is this: in our client here in Nigeria, I don't know if this will go well with many of our colleagues. and then how does that also work on our side, where call him a physician, call him a consultant, or a specialist in whatever area, sends a patient to you for something maybe they should have been able to identify, and you now identify it and send the patient back. One is, how would the physician receive that referral coming back? Some might, I don't know, they'll receive it well, or some will first try to, why would you send this patient back to me? And then secondly, we as probably therapists, are we going to summon that courage, maybe depending on the kind of institution where we practice, to say, oh, Dr. A sent so patient to me, and then I'm sending the patient back to the person. Of course, the therapist here was smart enough to itemize his own findings, which maybe the physician that sent the patient did not look at or did not observe in the first instance. I'm just now looking at it differently beyond, I'm just looking at the systemic issues within our client, because some of these cases, I'm not sure they were handled in Nigeria, so because we're looking at first contact physiotherapy practice, and then patient referrals, and you referring patient back and all that. I'm just raising a concern. I don't know if this can be addressed. Thank you.
Very important one. Very, very important thing. Because we can have all this knowledge and skills. If we cannot communicate them, and or possibly they are not accepted, then what have we achieved? Nothing. So, but let me tell you something. People that have ego, people that think they know, and because of what they know, because of their level, because of what they think they achieve, that they have that ego because of that. People like that respect superior argument. Try anyone that you think has ego. He may not show it, but they have so much respect for superior argument, because that's the something that made them to feel big, that they know more than anyone. The moment something comes and it's something that's superior to what they have presented, you rattle them and they hardly begin to fight you. They will be very careful because they respect achievements, they respect great heights. That is why they have that ego, because that's what they think they have. Someone is coming with something superior. So I think what I will advise us, let's master distance. Remember, I told you, if you send a referral one time, second time, and the physician or the specialist realizes that you did not do a thorough evaluation, and they have something against what you sent, and later realize that you were wrong in making that decision to send to them because it's just a yellow flag, you have not achieved a red flag. Whenever you send them again, even if it is correct, they are going to send it back. But when you're first and you're second, it's something that's very true. And the way you present it with a very good approach, only stating what you have found and saying that I think this might be indicating the presence of an organopathology or something like that, when you send it to them, it's very polite. It is not telling them that they were wrong. You are just saying that you stumbled on something that might need their attention. Believe me, there's not going to be any clashes or crisis. So what we need to do is just to advance ourselves in these areas, that we are able to have that confidence that what we have is correct. Wherever it goes to, it will be acceptable. And usually, if you lack confidence, it's because you don't have the skills. When you have the skills, believe me, the confidence, the skill will drag the confidence, and it will make sure that the confidence follows you. So let's just focus on this. Let's get the skills. Let's advance ourselves in these areas. Everything will sort itself out. Thank you very much for that. It's wonderful. Yes, so I think I'm going to share from another system. Yes, Mr. Anozie, you want to speak?
Yes, Prof. Please, from the last speaker, I could just see that could we arrange a training or sort of, maybe, I'm not saying that we don't know how to refer our patients, but the language of communicating these things is very important. Could we just maybe do maybe like an update course on really writing referral notes? Because I've seen that sometimes it's not just that they don't want to accept our referrals, but the way you write those referrals is really, really important. The language, the way you arrange it properly, and it comes to them, it's also very important. In as much as we also we are not, we don't accept some referral notes when they come and they say do aggressive physiotherapy to the limbs, and we feel like this is not appropriate referral to. Well, I'm asking ourselves, are we also presenting these things in a very logical manner and also very presentable manner that when someone reads this, he knows that, oh, you have a very logical pattern of thought and is well presented and is something I can look into, in such a way that you are not really throwing it into their face that, oh, you missed out something, I'm the one doing the medical diagnosis. But you present it in a way that, oh, I'm suspecting something and I need your expert review, something like that. Maybe it may help us to be able to navigate these problems with communication. Thank you, sir.
Thank you very much. Definitely, we're going to have something like that. I think if you go to the rehabilitation competency framework topics that MRTB has been doing every 2 weeks, I think there is one of those courses under practice that is on referral. So what we are going to do possibly this year, instead of the way it was done last year, we are going to ask them to emphasize on practical means of making the referrals. How do you write the referral and the approach to communicating with other health professionals when referring. I think we'll consider that. And Dr. Jibril Samani, I think we can also consider having it in Ray at some point in time. Let's see how we can improve our communication skills when it comes to referral. Thank you very much. That's a good one. The next thing I'm going to share, sometimes we just say the patient has depression or the patient has anxiety. But sincerely, what questions do we ask to be able to establish that there is depression or there's anxiety? So these are some questions. Have you been under a lot of stress lately? Are you having some trouble coping with life in general and or life's tensions? Do you feel exhausted or overwhelmed mentally or physically? Does your mind go blank or do you have trouble concentrating? You can't just ask the patient, do you have depression or are you anxious? People will begin to think, okay, what's depression? From what context and things like that. So these are some of the questions, very important. Do you have trouble sleeping at night? Do you worry about finances? Do you get any enjoyment in life? So these are some of the questions. And I think because of diversities, they have some questions for Asian clients, but we don't have those Asian clients here. I will not go through that. So I'll try to share many of these documents, but I believe if you go to Goodman and Snyder, you are going to see many of them. But I'll still try to share these documents that I've been sharing with you. Screening for depression in older adults. Okay, this is similar to what we have just looked at, so I will not share that one. And then I have screening for dizziness. Okay, let me share this because we have been talking about dizziness. How do we know there's dizziness? From the questions that we ask patients. Do you have spells of dizziness, vertigo, a sense of spinning? So sense of spinning. When does the dizziness occur? How long does it last? Does it come on suddenly or gradually? What brings it on? What makes it better? You may have to ask if the vertigo comes on suddenly, is caused by motion, or is brought on by change in position. So these are some questions. I just hope that at the end there will be aha. So this is what I'm trying to say. These are questions that you ask, but what is the interpretation? So for the therapist, are the vital signs stable? Because it might be that the BP has gone up, the patient has dizziness. So you'll be able to say, there's dizziness. Okay, let me go back and take the vital signs. That's why they are vital. There are many possible causes of dizziness, including but not limited to hypotension. So if the patient has hypotension, they will have dizziness. So you now want to ask some other questions or do some tests that will now make it a red flag. Oh, the BP is very low. That's why he's having dizziness. Okay, these two put together, let me quickly refer to the patient. Basilar artery compromise or bradycardia, bradypnea, fever, hypoxia, hypoglycemia, dehydration. Can you see a number of things? Just the patient-reported dizziness. It could be any of these organic pathologies. You may have to screen for alcohol abuse. That also make patients to have dizziness. You want to now rule out whether it is as a result of alcohol. Test for vertebrobasilar insufficiency if cervical spine involvement is suspected. So more specific diagnostic questionnaires for clients with reports of dizziness are available. These are the studies. If you go to Goodman and Snyder, you are going to see this in the chapter, or where this chapter is, you'll be able to see them. Okay, they are even shared here. Physical therapy assessment of vestibular hypofunction is there. Development of the dizziness handicap in the inventory. So when you go to this link, you are going to see those questionnaires that will help you to be able to know what the cause of the dizziness is. So that's another one that's important to understand. So what I'm trying to say here is that you say dizziness, you say anxiety, you say depression. How do you know it's there in the patient? What questions do you ask them? So these are some of those appendices that will help us to be able to know such things. Okay, let's see case study on delirium. This is neurological. I know we have done neurological, but we didn't take this particular one. So let me just quickly share and see if it is not long. Well, it doesn't have answers, so it's just to read through. In case we have read it, we'll leave it, but I don't think we have read it. The source is not Goodman and Snyder. So let's see this that comes from another source. Yes, can someone help read? This is the source. Rudolph, delirium or dementia. Yes, can someone help us read?
Okay, I want to read.
Okay, thank you.
Okay, good evening, everyone.
Good evening.
An 86-year-old woman admitted with complaints of shortness of breath and cough was found to have pneumonia. Her past medical history included cataract surgery, hypertension controlled with medications, and type 2 diabetes controlled by diet. She was ambulatory, lived alone, and at baseline completed all activities of daily living independently. According to her daughter, the patient was never disoriented. At admission, the patient appeared mildly dehydrated on physical examination. Her oxygen saturation was 94% on 2 liters of oxygen by nasal cannula. An arterial blood gas showed a normal PCO2 of 40 milligrams per mercury. Her daughter requested to spend the night at the bedside, but was told she could not stay. Overnight, the patient was noted to be disoriented by the nursing staff. She began pulling at her intravenous lines and attempting to get out of bed. The covering physician was called and ordered that the patient be placed in a 4-point restraint. The following morning, the daughter returned to find her mother in restraint, speaking incoherently and severely short of breath. Upon finding her mother confused, the daughter asked the nurse what had happened and reiterated to the nurse that her mother had never been confused before. The doctor was called, an arterial blood gas was performed. The patient's PCO2 was 91 milligrams per mercury and the PaCO2 was 58 millimeters per mercury. A marked increase since admission despite the patient's deteriorating clinical condition. The patient's worsening level of consciousness was attributed to senile dementia, not impending respiratory failure, as evidenced by the significant carbon dioxide retention. No further action was taken. Over the course of the day, the patient developed worsening respiratory distress and became comatose and eventually was transferred to the intensive care unit. She subsequently developed respiratory failure requiring intubation and requiring dialysis. Her condition did not significantly improve and she eventually died 2 weeks later.
Okay. As I've said, this is not a case that has answers, but they are querying delirium or dementia. So there are two systems, neurological system and of course pulmonary system that can be implicated there. So let me share another one, unless if anyone wants to make a comment. If you want to make a comment, I can reshare. And let me get another one. Or let me share neurological screening and see. Oh no. Good, good. I've got something, because some things were mentioned that I thought it's important for us to be able to identify what is within normal and things like that. So I've gotten something that's very important. So this is Neurologic Practice Essentials, a measurement toolbox. So a list of relevant screening items, easy to assess by questionnaire. So difficulties with vision, swallowing, speaking. So when you're looking at the vitals, what do you call this? Cranial nerves, changes in ability to smell, presence of strange odors, so the cranial nerves, then dizziness, lightheadedness, pain, changes in sensation, swelling, sores that will not heal, shortness of breath. These are all symptoms. Recent changes in medication, appetite. You know, we kept discussing the issue of appetite and weight, very important. We need to always ask about those things. Then these are reference, normal values of common laboratory tests. We need to know those things. Remember earlier, they talked about some of them. The issue of hematocrit, what's the normal for men and the normal for women, factors indicating need for further examination. So when you see them, that it indicates further examination or referral, but are not limited to this. So these are the things. So hematocrit for women is 36 to 46. When you have 30%, it means, so these are interpretations. Can you see very, very important things for us as physiotherapists? Very, very important things. So will you say that a physiotherapist cannot ask for laboratory tests when having the results of the laboratory test can indicate exercise capacity of the patient? That's why when I ask a physiotherapist, what's the difference between physical and medical diagnosis? They will say in medical diagnosis, you ask for radiological investigations and lab tests, but in physical diagnosis, you only assess the patients physically. I say, what does that mean? It means a physiotherapist cannot order for lab tests or cannot order for radiological investigations. I've explained radiological investigations. The radiologist is a medical doctor. What he knows is organic pathology. And therefore, if he gives a report of a radiological investigation, he is looking at the report from the perspective of treating organic pathology. I'm a physiotherapist. I don't treat organic pathology. I treat movement impairment. How can he give me information that will help me to treat my patient? When he's a medical doctor, he does not have any physiotherapy course in his curriculum when he went to school. And therefore, I need to understand how to read and interpret radiological investigations from the perspective of movement impairment. When he's thinking of the fracture and how to reduce it, I'm thinking of how close the fracture is to a joint that will affect the patient's movement at that joint after the fracture has been reduced. We think of different things, and therefore we are going to interpret different things. The same thing with this laboratory test. So you do this hematocrit test, HCT, you see the range. It's supposed to be 36 minimum. You see 30%. This means the patient will have reduced exercise capacity. When you come to give them exercise, you'll need to know what type of exercise and to what extent, what dosage that you need to give them. Below 30, markedly reduced exercise capacity. Any patient that reports this less than 24%, don't give them any exercise. So can you see objectively, for all those that are saying, let's just refer and not treat the patient because there is an organic pathology, they can come back here and say, When is it that I don't refer? I don't keep, I only refer. If the patient has 24% and below, you don't give exercise. Even that does not say don't refer, because it's only exercise that you don't give. It's possible you keep the patient and give them other things that are important for other symptoms that they have. Hemoglobin, for women 12 to 15 gram per DL, for men 14 to 16 gram per DL. But when you have 10 gram per DL, means reduced exercise capacity. So you can use the hematocrit or the hemoglobin to be able to know when exercise is contraindicated, when you can give it with caution, and when you can give it without any problems. Then the ESR. Elevated levels are indicative of inflammation and require medical follow-up. And therefore, anytime you have the ESR and it's elevated, higher than normal, then you know inflammation is an organic pathology. You want to refer the patient. You don't even need to know the cause. All you need to know is that there is inflammation or there is infection. You refer. Let whoever it is that's going to find out what it is to find out. Unless if in your system, you refer to specialists, you now want to look at the different systems and do systems review so that you will see from what system you have pathology that you'll attribute the inflammation or the infection to, and then you refer to that specialist. The INR, 1 or less. So see, all they are about exercise. So this is something that's related for us. Prothrombin time, used in patients anticoagulated in heparin, greater than 45, exercise is contraindicated. White blood cell, this is the range, requires medical follow-up. Anything above 20 millimeter cube requires medical follow-up. For the platelets, this is the range. If you have anything less than 60,000, no resistive exercises. Can you see even resistive exercises? There's a way you'll be able to know whether to give the patients. Active range of motion may be walking, so you can give. But less than 5,000 millimeter cube, no activity at all. Don't give the patient any activity. So we can ask for all this. If they query us, why do you give this? There are references to all this. Please, who is there? The admin, can you please help mute? Oh, it's even Ray Institute. Ray Institute, please, can you mute? Host. Yes, so these are the things, and we have blood chemistry, arterial blood gases, so cardiopulmonary people. Can you see, I think I can rotate. Yes. So sodium, patients with low sodium should be treated medically. So the moment you see low, you refer the patient. Potassium, anything greater than 5.5 or less than 3 may not be medically stable. For glucose, these values, limited activity. So these are the ones that we saw earlier, right? PaCO2 and PaO2. So anything greater than 50, because the maximum here is 45 for normal. Check with nursing before initiating a treatment. Check with nursing before initiating treatment. Check with nursing before initiating treatment. These are the things. 20 millimeter mercury. Check with nursing before initiating a treatment. And you have
with the nurses, please, sir.
Sorry.
What are we checking with the nurses?
Well, it's not within your scope of practice it's a medically well, that's let me say I don't know, because I've not really I will have to check this, but all we know is that before you treat, you check. I don't know. Let me find out. Or is there anyone that can explain
I have
this?
something to say. I
Yes,
think I can
please go ahead.
explain that.
Okay, sure, go
I
ahead.
work in the pediatric intensive care units, and
Good.
ABG is something that we regularly do for patients that are admitted there, and mostly intubated patients. So it's important that you know the status of the patient, whether a patient is having either metabolic acidosis or acidosis, or respiratory acidosis or acidosis. So it's important. You don't just rush in and treat the patient. So you review with the team members and see if the patient, if it's actually a metabolic thing, I mean, either bicarbonate is reduced or something. So they are doing it with medications. So it's good you check nothing like you said. So you review with the team and see if patient is quite stable with the figures the patient is having before you do anything. Really.
I think the question is why check with nursing? I think that was what the question was. We know it's important.
That's
we know why
saying.
it's important.
You check with the nurses to see actually the review of the ABG results.
Okay.
To see if it's metabolic acidosis or respiratory acidosis.
Okay.
So
good.
It's good. Yeah.
Okay, wonderful. I get it.
Yes.
I get
More importantly, also check with nurses that they are saying it's not physically checking with the nurses. They have nursing charts on the ward. You want to see how consistent that reading has been, because sometimes every 1 hour the nurses they do their chart, they record it. If you see the way it is being recorded, if it has been like the situation has been like that for long, you know that no, this one is a red flag.
Wonderful.
Yes.
Wonderful.
So
That's
the nursing
very
chart
good
is
idea.
what they are referring to. We should not ignore it when we get to the ward. We should check up with all those things before we take our decision.
Exactly. Okay, that's wonderful. You know, there are some conditions in which you see a particular reading just shoots up and then it goes down. But there are some that it shoots up and then it's maintained for a long period. So I think these are the things that you check to see the pattern. And the pattern is what will reveal whether you can be able to go ahead and give treatment or not. So that's a very good one. I think that was one of the conditions that we looked at that talked about the blood pressure or the difference between the two. Shoots up just at a point in time and then it comes back to normal. So you don't want to give exercise if it's maintained for a very long period at that higher level. But if it shoots up and it comes down and the patient does not have a high blood pressure at the time that you're going to treat. So I think this is important just to check, to see the trend. So, and who takes these readings over time is the nurses, and they put it in their nursing chart, and that is what Dr. Ajiboye is saying, that we check that to see the consistency of the readings and the trend of the readings. So now I can see something also myself. So can you see what I said? You can teach and also learn at the same time. Thank you so much to all those that have contributed. There are references to this, but it's very important for us really to study these things and make use of them as physiotherapists. Let's not just be attributing them to the medical people. And see a review of body systems. There are things like the issues of the vital signs. This also interpreted. So anything above 100, irregular rhythm. So important. Don't just say, I've taken the heart rate. What does it mean? What does it mean? Very important. For integumentary, you have the issues of skin color and you have the interpretation. I like this document. When I got it during my DPT, I was studying it a lot. For a long time, I've not studied it, but it's something really that I appreciate, because that issue of evaluation is a very key thing to our practice. And all those issues that we're seeing, when you refer, they reject it. If you have all these evaluations and they can be referenced, say, I asked for that lab test because I want to see the level of this or the level of that. That is going to determine what I'm going to do. And if it is a referral, you are also given justifications, these evaluations to defend why you did what you did. See musculoskeletal systems, limitations in ROM, inability to demonstrate full active ROM, so perform in sitting or spine, perform active ROM. So these are things that are important. Gross strength, remember, it's in history. They use gross strength, but when you go to examination, it has to be the chart. There is nothing like gross muscle power 3/5. There's nothing like that. I can be confident to say it anywhere. When I'm taking history, I say, do you have any weakness in your body? I say, yes, I have weakness across my upper limb. I will say gross strength problem or something like that. But when I come to assess, when I say lift your hand and I resist the movement of the hand at the shoulder, then I'm only assessing shoulder flexion. So if I say 3/5, it's only the shoulder flexors. But what happens to the wrist extensors? What happens to the abductors? What happens to the extensor at the shoulder? I don't have readings. And there could be a condition where you'll have 2/5 in one muscle, 3/5 in another muscle, 4/5 in another muscle. especially conditions that have relations with affecting more distally than proximally or the other way around. And therefore, there's nothing like gross muscle power or gross strength when it comes to examination. Height and weight.
I'm sorry, sir.
Yes, ma'am.
In
yes,
the case of spastic paralysis, spasticity, can we isolate the grading of the muscles?
If you have spasticity, what that means is that you have an upper motor neuron lesion.
Yes.
And if you have an upper motor neuron lesion, you are going towards more of abnormal synergies than muscle strength. So
Yes.
you can isolate the joints. How do you even assess the muscle power across groups of muscles? So what you do at that point that you have the spasticity as a result of upper motor neuron lesion, you assess. So for example, your Fugl-Meyer assessment, that is going to assess the synergy, and then you use your tools for assessment of the spasticity. You treat the synergy, you treat the spasticity, but at the point that you begin to have individual joint movement, then, for example, in stroke, you know, apart from the synergy problem, over some time, 3 things happen to the muscles. Number 1, the number of motor units will reduce. The firing or the discharge of the impulses also will be affected. Then the recruitment process. Sometimes you need to recruit the slow twitch before the fast twitch, or the other way around. That recruitment process will also be altered. And it is at that stage that you now begin to give strengthening exercises and then you now do the gross muscle power. Sorry, the muscle charting. But in the initial stage, when you have the abnormal synergies, you assess the synergies, you assess your spasticity, you treat the synergies, you treat the spasticities. That is what you do at the initial stage when it is upper motor neuron. But if it is lower motor neuron or orthopedic cases, then your charting is very, very important. Yes, so neuromuscular, I can't go through all of them, but sincerely, I will tell you this is a document that I will hold very tight to myself because of the interpretations. So I'm going to send this document to you immediately after this. I think we are already 10:13. I don't want to really keep you too long, but let me see if there's any other thing that I need to share that is important. A screening of the neurological system. I think, okay, this is a PowerPoint. I think we did pediatrics, but I don't know if we have case examples. What do you think? Should I just send documents for you to study, or do you want us to share 1 or 2 because we have hematological and endocrine? What do you want us to do? Should we share 1 or 2 more, or do I just send them to everyone to study individually?
Let's share it, sir.
Okay, I should share with the group, right? And not open it here.
Oh, explain.
Sorry?
So we still prefer you send us the document too.
You send the document, but you explain to us so that we can grab the thing well when we see the material.
Okay, so that's fine. So I will send it on the other group. So what that means is that we should end the class here. Is that what you are saying?
No.
Okay.
Sir, we need to, the class should continue.
Okay, wonderful. Okay, that's fine. Okay, let's share 1 or 2 more. Okay, that's fine. So let me just share on a few. So I'm going to send this screening. Please study the screening very well. Evaluation is one of the most important things when it comes to diagnosis or when it comes to system review issues. So this is, I think we have done, did we look at Cushing syndrome? Was it Cushing? I don't think it was Cushing syndrome that I shared. Let me see. Okay, let me share this because it's bringing in something important. If we have done it before, let us know so that we share another one. Okay, so can someone read the history?
I think we have shared this one before, sir.
How we have shared, right? Okay, I was thinking that we did share this. So let me open another one. You know what I did was to open each folder and just pick one when we had the class earlier. So let me share something different. Okay. Good. So there's something that has laboratory tests. Let me share that so that at least we'll also have a follow-up from that table with lab tests that we looked at. So can someone help read this?
Okay, a 38-year-old woman with right-sided groin pain was referred to physical therapy by her physician. She says that the pain came on suddenly without injury. The pain is worse in the morning and hurts at night, waking her up when she changes position. The woman's symptoms are especially acute when she tries to stand up after sitting, with weight bearing impossible for the first 5 to 10 minutes. The woman, who looks athletic, reports that before the onset of this problem, she was running 5 miles every other day without difficulty. The X-ray finding is reportedly within normal limits for structural abnormalities. Erythrocyte sedimentation rate, ESR, was 16 millimole per hour. The client has chronic sinusitis and has had 2 surgeries for that condition in the last 3 years. She is not a smoker and drinks only occasionally on a social basis. This client was seen 6 weeks ago by another physical therapist who tried ultrasound and stretching without improvement in symptoms or function. Clinical presentation. The physical therapy evaluation today reviewed a positive Thomas test to right hip flexion contraction. However, it was difficult to assess whether there was a true muscle contracture or only loss of motion as a result of muscle splinting and guarding. Patrick's test, FABER, for hip pathology and the Iliopsoas test for intra-abdominal infection were both negative. Joint accessory motions appeared to be within normal limits, given that the movements were tested in the presence of some residual muscle tension from protective splinting. The neurologic screen failed to demonstrate the presence of any neurologic involvement. Symptoms could be reproduced with deep palpation of the right groin area. There were no active or passive movement that could alter, provoke, change, or eliminate the pain. There were no trigger points in the abdomen or right lower quadrant that could account for the symptomatic presentation. There was no apparent cause for her movement system impairment. Physical therapy intervention with soft tissue mobilization and proprioceptive neuromuscular facilitation techniques were initiated and used as a diagnostic tool. There was no change in the client's symptoms or clinical presentation as the therapist continued trying a series of physical therapy techniques. Results. In a young and otherwise healthy adult, a lack of measurable, reportable, or observable progress becomes a red flag for further medical follow-up. The results of the physical therapy examination and lack of response to treatment constitute a valuable medical diagnostic tool. Further laboratory results revealed a medical diagnosis of Hashimoto's thyroiditis. Treatment with thyroxine T4 resulted in resolution of the musculoskeletal symptoms. The correlation between groin pain and loss of hip extension with Hashimoto's remains unclear. Even so, response to the red flag, no change or improvement with intervention, resulted in a correct medical diagnosis. The ESR, an indication of possible infection or inflammation, was within normal limits for an adult woman.
So initially, I thought, thank you very much. Initially, I thought it was going to be a case that the ESR had shown that that's what the problem of the patient is. But later I realized that was not the case. So what they ruled in was an endocrine problem, isn't it? And they ruled out an infection because the ESR, they said for females, was within normal range. And if it was outside the normal range, we would have suspected that there was an infection or at least inflammation, and then the referral would be based on the fact that the musculoskeletal tests were not positive because it was an infection. But see, the ESR did not indicate the need for referral on that basis, but they ruled in the issues of endocrine disease. So just to remind us of some of the things that we'll need to ask to be able to confirm such conditions. Do you remember these slides that we looked at last Saturday? Signs of thyroid storm, issues of tachycardia, elevated core body temperature, restlessness, agitation, abdominal pain, and things like that. So remember signs of potassium depletion and a number of other things. Red flags, palpable nodules in supraclavicular area, multiple eruptive symptoms, signs of fluid loss or dehydration in patients on diuretics. So just sharing. Then these are some of the yellow flags: past medical history of endocrine or metabolic disease, bilateral carpal tunnel syndrome, and a number of other things, just so that we'll know when we see situation like this, what further questions do we need to ask before we establish that it is an endocrine problem, so that we send to the endocrinologist. So let's see if we'll share another study different from these ones that we have seen. This is case 5, 10, 11. Just let me know at some point when you want us to stop taking them. Palpable and observable lymph nodes. So this one is not too long too. Essentially, all mouse referred to by oncologists. Okay, this is an oncological case. So let's just quickly take the oncological case. Yes, can someone help read this?
Brief history.
A 73-year-old
okay.
was referred to a therapy clinic by her oncologist with a diagnosis of cervical radiculopathy. She had a history of uterine cancer 20 years ago and a history of breast cancer 10 years ago. Treatment included a hysterectomy, left radical mastectomy, radiation therapy, and chemotherapy. She has been cancer-free for almost 10 years. A family physician, oncologist, and neurologist all evaluated her before she was referred to the physical therapist. Examination by a physical therapist revealed obvious lymphadenopathy of the left cervical and axillary lymph nodes. When asked if the referring physician or other physicians saw the swelling, she told the therapist that she had not disrobed during her medical evaluation and consultation. The question for us as physical therapists in this situation like this one is how to proceed.
Okay. Maybe let's quickly discuss this. I think very interesting, isn't it? This is something that is we expect that a physician will do, not a physiotherapist, really, to really begin to look at lymph nodes. Can you see how important it is? Where are even the lymph nodes? How do you palpate them? What do you see? Remember, we discussed this, I think, was it when we were doing the endocrine? Yes, endocrine. I think I emphasized that. Let's find out where they are located, how to test them, what do you feel, and when do you see there is a problem there? Very important. The physician missed it. The physical therapist found it and referred. Maybe, do you want to make any comment, or do you want us just to quickly read the answer? Okay, let's go ahead and read the answer.
Do I continue?
Yes, ma. Yes, please.
Several steps must be taken. First, the therapist must document all findings. If possible, photographs of the chest, neck, and axilla should be obtained. Second, the therapist must ascertain whether or not
steps must be taken first. The photographs of the chest will be obtained.
Neck and axilla. So, the therapist must ascertain whether or not the physician is already aware of the problem and has requested physical therapy as a palliative measure. Requesting the physician's dictation or notes from the examination is essential. Contact with the physician will be important soon after the records are obtained, either to confirm the request as palliative therapy or to report your findings and confirm the need for medical re-evaluation. If it turns out that the physician is indeed unaware of these physical findings, it is better to send a problem list identified as outside the scope of a physical therapist, in quotes. When returning the client to the physician, be careful to avoid making any statements that could be misconstrued as a medical diagnosis.
Wonderful.
We recommend writing a brief letter with the pertinent findings and ending with one or two one-liners. What do you think? Please advise. Okay, those are the type of things we can ask the physician to do for us.
Thank you very much, Ma. Something very interesting here. It's very possible when you ask the patient and they said, I didn't even disrobe, and therefore you assume that the physician is not aware of that problem that you just identified. But if you now just write to say that this is what I found, which was not there initially in the report, and the physician is aware of it, they will feel offended. Well, I already know. What are you telling me? There's nothing new. And therefore what they're saying here is that it's important to now find out, is the physician aware of that, what you have found? Before you now begin to say, if they are not aware, okay, let me now give that information for them to be able to take it up and use it further. Any other comment? At least I'm seeing very interesting things. Can you see quotes that are talking about it's outside the scope of my practice? Can you see the issues of what do you think? Please advise, so that at least if anyone has any ego, they will not think that your approach is trying to indicate that you know better than them or you know what is within their scope of practice. As I've said, it's a continuum. You can go to an extreme end of being polite. You can also go to an extreme end of being rude. The other time we saw one case report, someone said, no, I wouldn't say this. Like, it's too polite beyond what I can take when I relate with the physicians. But then, on the other hand, also you can go to the other extreme. So maybe moderation is important. But this kind of wordings are really important as we relate with others in the multidisciplinary team. Yes, thank you. Any comment?
Prof, sir?
Yes, sir.
I like to ask this question. I want to know your mind regarding taking a photograph. Okay. You know, we are in this part of the world whereby some patients may feel offended. Now, this is a female patient, and you are acting, you want to take a photograph, you know, maybe using your phone or what have you, the cubicle. If the patient decline or raise an alarm, what do you think that the physiotherapist should do?
Okay. Number one, I would start by checking if there is any evidence. So we are in evidence-based practice era. I will first of all find out if there is any evidence for the use of photograph to indicate presence of a pathology or a symptom or a sign. I will do that. So I'll just go to databases, relevant databases. I'll pick this a question. Can I use photograph to indicate the presence of a large lymph nodes in patients with suspected this or that? So that's my question. Then I will now break it down into keywords. I will combine them. I will do the search. If I see an evidence, then I can be able to communicate to the patient that research has shown ABC can be used to indicate this and that, either for follow-up or for communication with other professionals. But of course, we know if they go there, They can palpate, unless if you are thinking it will disappear, they wouldn't have seen it. You now want to show evidence that it was there if it's something that will disappear, but if not, they can't be able to do that. So I think it's all about the situation, it's all about the evidence, it's all about your ability to carry the patient along, get their perspective, also share your own perspective, try to convince them that your perspective is good, is going to help them, and then getting their consent. And because the workshops that we're doing in MRTV, you see that just like you do research, it's not just even about exposing them and taking pictures. Anything you do, you are going to ask for their consent. In some climes, they will even have a signature that the patient has agreed. I think there was a case recently, was it ABU or I can't remember what hospital, that a patient was accusing the hospital of removing maybe the womb or something like that without consent. And the hospital went back to the records and they got, I think it's AKTH, Aminu Kano or Ahmadu Bello University. So that consent is important. If you keep it, they have signed, let's assume it's the picture. They signed. I want to take the picture because evidence has shown it's important. This is what is due to you. Oh, I agree. Okay, can you sign? They sign, you keep it. If there is any problem later, you produce it. And that is what is going to protect you in any medical legal issue or case that will arise. So I think it's a very important one. And there are ways to really be able to sort out issues like that.
Hello, Prof.
Yes, ma'am.
Please, I want to make a comment. Something happened in our institution. One of our professors, he was about to do his inaugural, and he had pictures he had taken, and from patients with their consent. But now, when it's now time for that inaugural, he now said, he had to go back to those patients to let them know he was going to be using their pictures, to produce his book and everything. Yes. And many of the patients declined. But they had given consent before. You know what you said now that made me think about that. They had given consent for the pictures to be taken. But then now we do that consent for the pictures to be used for the inaugural lecture. Exactly. So I think it's something we really have to deal very seriously with because of medical legal issues. Thank you, sir, for the question.
Thank you very much. I think the agreement will contain what context and what scope that the agreement will cover. And that is why sometimes you find out that documentations like that, you bring in lawyers, because the statements and the terminologies and the wordings you use could have different implications and different interpretations. So it's very possible when they give the consent for the pictures to be taken, maybe you'll say it's just for the purpose of writing a paper, publishing it. But they'll say in that inaugural, people will come that know me, and I don't want that shared with people that know me, even if it's not going to show my face. But if it is a journal, it's not everyone that reads journal, it can just go out. That is possible. And therefore, if he says it's for publication, or maybe he will say it's for teaching in class, or he will say it's just for record purpose, they agree. If he's going to do something different from what is in that agreement before the consent is signed, he must seek for permission. And if he goes ahead and uses it, even though he has permission for it to be taken, then they can sue him, and then there can be a problem. So very important. I think we'll take note of that and include it in one of the courses on professionalism so that we can be able to have more legal people talk to us about the implications of these things. Thank you very much, Ma, for that. Okay, AKTH, yes, I remember it was either AKTH or send documents and share them. Okay, wonderful. Thank you very much. It's already 10:35. I don't think I'm going to share any other one. I will appreciate you so much for the patience. In fact, I'm so happy that usually when we do workshops, say, should we stop? And everyone will say, yes, let's stop. We'll just send documents. But I see people eager really to continue, to share more, to discuss more. I appreciate you. This is the last one that we are going to have on systems review for now, because systems review is a continuous thing. This is something that we take in a whole semester that we just took in 2 weeks. We can't exhaust the whole thing. We'll continue to do courses on this over time. But let me implore you, please and please and please, as we go to our place of work, every patient we see, even if we can't review all systems, let's try as much as possible not to finish clerking patient without taking one system and reviewing it. Please, over time, it will become more automatic that you can even review 2, 3, 4, or 5 systems in the same patient without seeing that you have taken a lot of time. So with this, I'm going to close and say thank you. May God bless you all. Dr. Samani, you or Hafiz, I will hand over to you if you have any comments or announcements.
Thank you very much, sir, for these lectures. And thank you everyone for being with us. And today is the last day for the clinical spotlight lectures. And we are going to start neurophysiotherapy on Saturday. Thank you, everyone.
Thank you.
The certificates that we have not gotten some certificates. Can you just comment on it, please?
The certificates will be shared to you.
I'm behind by 2, please, and I've sent you a message. I know you. It's a lot for all of us disturbing you, but please, thank you so much.
Let me just say something about the issue of certificates. Maybe if it might be a good idea. There is a company, I think it's a prosthetic and orthotics company. They developed an app or a software that helps with things like this. So they presented to us. When your participants go in and they sign in and you capture everything, there is a certificate there that at the end of the day, you just click the names of everyone. You click, automatically the certificate will just have their names and it will send it to them at one click at the same time. They said it was 500 per certificate. We told them we'll collect a really very small amount, 3,500 in some instances like the MRTV 1,500, and they agreed to reduce it. So we are now discussing with them what we are going to do is to use it and test it and see if it's going to work, so that immediately after the workshop, we'll just have a click and everyone receives it. And if everyone is happy with that, then we'll continue to use it. I want to apologize that certificates are not gotten on time. I think they are even trying because it's not easy producing the certificate one after the other, especially when the number of people is a lot. So maybe we'll try that. Hafiz, let's discuss how we can begin to use that Zikoro app to see how we can sort out this issue of delays.
Thank you so much. Mr. Hafiz, well done. Thank you so much, sir.
Thank you very much, Prof.
Thank you, Prof.
Thank you.
We really enjoyed it.
Thank you, all the admin people. Good night, colleagues.
Thank you, admin. God bless you
Thank
all.
you. Thank you, everyone.
Thank you,
Good night,
Prof.
everyone.
Thank you. Thank you. Thank you. God bless you. Such a
Good night.
wonderful time. Good night.
Thank you, sir.